Previously, we talked about the generalized vertebral body and the vertebral segment and the spine generally and its appearance in terms of radiograph and imaging. But in this specific lecture, we're going to talk about the cervical spine and how it actually looks on a radiograph and what are actually the different type of radiographs that we can use for it. And for that, we need to take a look at the basic anatomical structures and landmarks in the cervical spine and then actually visualize them on a radiograph or an imaging scan. And for that, we're also going to talk about the different views that we have available, like the lateral view, AP view, oblique view, and functional view, etc. So starting off with a typical cervical vertebra, which is C3, C4, C5, and C6, and they have one specific property which is actually very different from others, which is the presence of a foramen transversarium or transverse foramen, and it is actually the place through which the vertebrobasilar artery actually goes upward and then actually supplies the structures that it is meant to. And for that reason, it is actually easily characterizable as that this vertebra, for example, is a typical cervical vertebra. Another difference in typical cervical vertebra from other vertebrae is in the shape of its spinous process. It's actually a bifid spine, which means it has two ends, and because of its bifid appearance, it is easily characterizable or distinguishable from other vertebrae if you want to identify it. Moreover, it has those similar structures such as body. However, it is smaller as compared to thoracic and lumbar. It has the articular processes. It has smaller transverse processes, and then once again, two superior facets, two inferior facets, making the facet joints, making the intervertebral joints, and all of those regular features of all other segments. Otherwise, it's pretty much the same, but those few structures such as the bifid spine and foramen transversarium makes it easily distinguishable from other segments. However, whenever we talk about the cervical spine, there are the atypical vertebrae as well, which is the C1, C2, and C7. Talking about C7, first of all, it is not that much different from C3 to C6, but its close resemblance with the thoracic vertebra, because it's a transitional vertebra, makes it slightly different from the typical vertebra, and for that reason it is considered as an atypical vertebra as well. But two other vertebrae which are actually very different in their appearance, and even though they are cervical vertebra, but their different shape and morphology make them an atypical vertebra, and that's C1 and C2, also known as atlas and axis. So talking about the atlas or C1, it has an anterior and a posterior arch, and it does not have a vertebral body, unlike other typical cervical vertebrae, as you can see here. So this is the anterior arch and this is the posterior arch, and then once again two lateral masses which can be said to be as the transverse process. But however, it does have the foramen transversarium, which is the characteristic feature of the cervical vertebrae, and thus it is considered as a cervical vertebra for that reason. And it articulates superiorly with the occiput, making the atlanto-occipital joint, and inferiorly with the C2, and the C2 and C1 make the atlanto-axial joint. So this here is the C2, and these are actually the superior articular processes, C2, which articulate with the inferior articular processes or facets of the C1, making the atlanto-occipital joint. But talking about the C2, it also has a feature which makes it different. It once again has a dens, which is a longitudinal elongated structure that articulates with the anterior arch of the C1, making the atlanto-occipital joint in combination with the two facet joints. And however, it does have a bifid spinous process. So this odontoid process or odontoid peg, also known as dens, is what makes it an atypical vertebra and unique in its structure. So odontoid peg or dents is actually a vertical projection of a bone, which you can see here, and it is located or oriented anteriorly, not posteriorly, and it extends superiorly from body of C2 and articulates with the anterior arc or the posterior aspect of the anterior arc of C1 or atlas. So here we can see that this here is the typical cervical vertebra, which is C3 to C6. And here we have the atypical vertebrae, the C1, C2, and C7. So here we can see the C7 is different from C3 to C6 because it does not have a bifid spinous process. Otherwise, it's pretty much the same. However, it also has a slightly longer transverse processes. Now, talking about the typical vertebra and comparing it with the atlas and axis. So, talking about the C2 or the axis, it does have a spinous or a process which is bifid, but the talking about the vertebral body, it has the dance or the odontoid process on top of it, whereas there is no dance or odontoid process in the typical C3 to C6 vertebra. Moreover, if we talk about the atlas, so once again, atlas does not have a body, it does not have a proper bifid spinous process, and it articulates with the dance via the anterior arch, and these actually structures and differences make these atypical vertebrae slightly different from the typical cervical vertebra. Now that was all about the landmarks, but now let's come to the radiographs and the imaging scans, and we go for cervical spine radiographs in patients who have suffered major trauma. And the importance of cervical spine is that because it's highly mobile yet highly specialized and sensitive area, and very important one as well because of its lodging of different important structures such as vertebrobasilar artery and spinal cord, etc. So talking about the patients who suffer major trauma, there are 3 x-rays which are mandatory to be done, and one of them is actually the lateral radiograph of the cervical spine, and that is why it is very important. And then we have the frontal chest x-ray. As you can hear, this is the lateral cervical radiograph, this is the frontal chest x-ray, and the frontal radiograph of the pelvis, as you can see here. So whenever we have a patient who has suffered major trauma, these 3 x-rays are mandatory for that person. Moreover, if we go into the depth into the indications for when we should ask for a cervical spine radiograph is the neck pain or tenderness, all the signs of direct neck injury, abnormal findings on a neurological examination such as radiculopathy or myelopathy, etc., severe head injury or facial injury, and near drowning. So these are some of the indications in which we can ask for a cervical spine radiograph. Moreover, if we talk about the radiographs for suspected trauma cervical spine, there are different type of images that we can get. One of them is the AP view. It is very popular. It actually gives us an anterior posterior image, and if we can see the alignment of the spinous process, and in terms of rotation, if they have been rotated or not. We can also look at the alignment of the mediolateral orientation of the articular pillar as well as the spinous process. We can also look if there is any scoliosis or not, and if we take a look, it's very well aligned, it's pretty much straight. There is slight angulation over here, which is this is the left side, so which is actually the convexity towards the left side and concavity towards the right side, and that is perhaps because of the fact that there is because of the hand dominance, because which is known as the handedness posture, and that can perhaps be the reason of this. Otherwise, it's pretty much a normal x-ray. And talking about the lateral view, in that we can analyze the spinous processes, the vertebral bodies. We can also look at the disc and the articular pillar, and we can also look at the normal lordosis or the angulation. For example, if there is straightening of the cervical spine, or if there is increase or decrease lordosis or something of that sort. And whenever we are taking a lateral view, this is a lateral view here, we can actually apply traction on shoulders to assist visualization of the lower cervical spine. But one important thing is that we should not apply traction to the head. And moreover, if we want to take a more clear view of the lower cervical spine, we can go for a swimmer's view. So wherever lower cervical spine is obscured by the shoulders, so lateral view with one arm up and one arm down, and a traction on head must never be used. And here we can see this is the shoulder mass is obstructing the lower part of the cervical spine, and here we can see that we cannot visualize C6 and C7 properly. So raising one hand actually up causes the depression of the other hand, and then we can clearly identify the structures in the lower cervical spine as well, and that can be important depending on your purpose for that. We were talking about the AP view, and there's one another determinant of AP view, which is AP open mouth view, and it is very important if the purpose of our scan is to look for the odontoid peg or the odontoid process or the dents. So here we can see we have the C3, we have the C2, and if we want to look for the this is the C2 spinous process and the C2 body, and then here we have the dents. And if we want to see if there is a fracture of the dents or if there is any problem in the dents, we can actually use this one as well. And here we have the C1, the lateral mass of C1, which is actually enclosing the dents, which is articulating with the posterior aspect of the anterior arc of the C1. So that is very important for the problems related with the atlantoaxial joint or the suspected fracture of the dents or the odontoid process, for example. We also have the oblique views, which are actually at an angle and they are tilted, and they are very good if you want to visualize the facet joints and the intervertebral foramina. So if you look at this radiograph here, we can actually look at the foraminas, intervertebral foraminas, and we can actually visualize how much space is there, and if they are actually there's narrowing of them, we can actually predict that there may be an increased compression on the spinal nerve roots exiting from these foramen, and these are performed where facet joint dislocation or locking is suspected. And other than that, we also have functional view radiographs of cervical spine, and they're used to diagnose posterior or anterior ligament damage. And the functional views are the lateral radiographs in flexion and extension and with the patient erect. And in this, we do not move the patient's head passively, and actually it is moved by the doctor or the person who is doing the radiograph. So that was all about the cervical spine and the different type of imaging techniques or scans or the views that we actually use in the cervical spine and their indications. I hope you learned something new out of it. Keep watching sqadia.com for more lectures like this. Thank you very much.